So malignant hyperthermia, and you can see this on page 168, is a potentially fatal adverse metabolic reaction to general anesthesia. So this is genetic, and it can be fatal. Okay, so the patient has just received general anesthesia, so it's not just going to randomly happen. So this is a general anesthesia that a patient has received. They will experience a rapid rise in body temperature, so they'll get super, super hot. Their temperature is going to be out of control high. Tachycardia, so their heart's beating fast. Tachypnea, they're breathing fast, and their muscles are going to be really, really rigid. So family history is going to be a big thing. So this is when you go in for surgery and somebody says to you, okay, have you had any previous reaction to anesthesia? Do you have any family history of reaction? So say this happens, these people basically need a code typically. So in the hospital that I work at, the overhead call, so code blue, right? That's when somebody's essentially dying, right? Their heart stopped, they're not breathing, so it's a code blue. They actually have a code blue malignant hyperthermia caveat onto it, just to let you know that that's happening. So if that happens, a patient has to receive dantrolene for reversal. So by law, all healthcare institutions that provide general anesthesia must keep a certain amount of dantrolene on hand in the event this happens. So dantrolene is how you treat malignant hyperthermia. Dantrolene is a muscle relaxer. So if you see dantrolene, I want you to think malignant hyperthermia. So during surgery, the anesthetist notes that the patient's heart rate is gradually increasing and becoming more irregular. The patient's blood pressure is becoming unstable, and the patient is starting to sweat profusely. What other assessment should the anesthetist note immediately? So, right, surgery, their heart is beating weird, their blood pressure is weird, they're sweating, you're thinking malignant hyperthermia, okay? So what should they be looking for? And we're looking for temperature because we know that that is tied into malignant hyperthermia. So you would think malignant hyperthermia in this question. You would say, okay, temperature is a big indicator, and then you're going to give them dantrolene. All right, next is moderate sedation. You can find this on page 169. So we call this conscious sedation, procedural sedation. It does not cause loss of consciousness, okay? So that's the big difference. General anesthesia does, moderate sedation does not. It's typically a combination of an IV benzodiazepine and an opiate analgesic. We use a lot of midazolam, which is a benzodiazepine, and fentanyl, which is an opioid. So we use that a lot in the ER. So the patient's not going to be anxious or sensitive to pain, but they can't recall the procedure. This does not mean you say terrible things, right, when they're asleep, because we want to act like they're going to remember everything. But sometimes patients come to the ER and their heart is out of rhythm. And we try all these drugs, it doesn't work, and they're unstable, right? Their blood pressure is decreasing. So sometimes we will do a cardioversion, which is shocking them. So they're not trying to die or anything, right? Their heart rate's weird, their blood pressure is weird, they're not doing well. So we'll shock them. So prior to doing that, we do a moderate sedation where we give them quick acting medication, do the procedure. They typically come back, I would say in like 2 or 3 minutes after they'll wake up. So very, very fast. However, these are dangerous medications, right? The patient might not. So this, probably how everybody is, but this is how the hospital I work at is, the physician has to be there, respiratory therapist has to be there, you need the crash cart, and 2 nurses. So that is how we do moderate sedations. It's a very, very high risk procedure. Everything needs to be documented to the T because the patient may not wake up. So everything needs to be there. The patient may need to be intubated. But in this case, when the moderate sedation is occurring, the patient can breathe on their own. So they do not need to be intubated. Which statement regarding conscious sedation does the nurse identify as being correct? A, the intravenous route of drug administration is commonly used in pediatric patients to provide conscious sedation. B, mild amnesia is a common effect of midazolam. C, patients receiving conscious sedation must be intubated with an ET tube, endotracheal tube. D, effects of propofol include relief of anxiety and pain. Okay. All right, so mild amnesia, right, forgetting is a common effect of midazolam, which we don't want somebody to forget that we just put electricity on their chest. That hurts. Try not to use IVs in patients, little guys. And then the patient does not need to be intubated in conscious or moderate sedation. So how does moderate sedation differ from general anesthesia? You got it. General anesthesia requires intubation and moderate sedation requires no intubation. All right, and then local anesthetics, this is page 169. So this is, as we talked about, surgical, dental, or diagnostic procedures, treatment of certain types of chronic pain. Sometimes they'll do kind of like a nerve block, that would be with lidocaine. Spinal anesthesia controls pain during surgical procedures and childbirth. So local anesthetics are given by infiltration, so they put it into the area, or a nerve block where they put it around the nerve to numb the area. We have some different types of local anesthesia here. And if you look on page 170, box 11.2, we have types of local anesthesia. Some adverse effects here, and this is usually limited. So these are of local anesthetics. So inadvertent intravascular injection. Sometimes they'll put some epinephrine with it to control the bleeding. That's, you know, something that constricts blood vessels. That may have something. Putting the wrong medication in, maybe injection into something highly vascular, right? We want it to go into the soft tissue. We don't want it to go into systemic circulation. One thing to talk about, though, is a spinal headache. So a spinal headache occurs, and this is on page 171, in patients who have received a lumbar puncture or who are undergoing intrathecal anesthesia. What happens here is we have the spinal cord, right, and that's covered by this sac. So, you know, we're putting a needle into that area. When the needle's withdrawn, some part of that cerebrospinal fluid, just the fluid around it, can leak out. Due to that decreased pressure, you can get this really, really bad headache. So what we want the patient to do is stay well hydrated and lay flat, typically self-limiting. Caffeine may actually help this. Some patients will still have a headache a few days later. There's probably one patient I've seen in the ER who has this. She said 3 days, I think she had just the worst headache ever. She was laying flat, she was drinking caffeine, trying to drink fluids, and it wasn't getting better. So they did a blood patch. And a blood patch, you take the patient's own blood, and then it's injected into that area of the spine, and it actually clots. So you don't have to put anything else. It's the patient's own blood. Doesn't cause any adverse effects. It is effective in treating spinal headaches in over 90% of the cases. So we obviously don't want to inject anything into the back around the spine. Obviously, you wouldn't want to inject anything in your brain unless we have to, but that headache can be so bad that that's the only way to do that. All right, when teaching a patient about spinal headaches, which statement will the nurse include? A, spinal headaches can be prevented with bed rest after the epidural procedure. B, patients who have a spinal headache should have very limited fluid intake. C, a graft of the skin from the patient's hand can be used to seal the leaking area causing the headache. Or D, high Fowler's position should be used for patients who have a spinal headache. All right, so they should have increased fluid intake. So B is wrong. C, we're going to do a blood patch, not a skin patch, so that's wrong. And D, how should they lay? They should lay flat. So high Fowler's position is like 90-ish degrees. We don't want that. All right, so this next area, page 172, is neuromuscular blocking agents. So we call these paralytic drugs, so they paralyze people. That's a huge deal. Artificial mechanical ventilation is required. So you're gonna paralyze somebody, including their diaphragm, so they can't breathe. What happens if they're not ventilated? They're gonna stop breathing, right? So that's lethal. So we need to ventilate these patients. Paralytics do not do anything for sedation or pain relief, so the patient's still awake. So they may still be conscious. So we want to include a pain reliever, right? And we want to include anesthesia, and they have to be intubated if we're giving these drugs. So an example of this is succinylcholine. So this is going to be similar to the neurotransmitter acetylcholine, causes depolarization. I don't think that matters. But it results in a flaccid muscle paralysis. So that is going to be concerning because we would want to give the patient a general anesthetic before giving this, and we're going to want to make sure they're intubated. So this is how it works. So you give this drug, right? We give succinylcholine a lot. In patients in the ER, we give etomidate and succinylcholine typically prior to intubating. So we would give etomidate first because that is a anesthetic, and then we would give succinylcholine because that's a paralytic. So when this happens, we give it and they get muscular weakness. They're followed by total flaccid paralysis. So the small, rapidly moving muscles are affected first, like fingers and eyes, then the limbs, then the neck, then the trunk, finally the intercostal muscles and the diaphragm. That's how we breathe. And then they have no more respirations. And then when it's wearing off, which, I mean, it's really rapid that it starts. It's half-life. It lasts for like 6 minutes. So when it's wearing off, they're going to get their first movement back in their muscles and in their chest cavity. Then they're going to get it in their trunk, their neck, their limbs, and then the small muscles. All right, a patient is to receive a neuromuscular blocking agent. So when we see that, we think paralytic while they're on mechanical ventilation. While the patient is receiving this medication, the nurse should expect the patient to be sedated. We do not want to give a paralytic without sedation. All right, so some nursing implications here. And again, if you look at this back section of your book that starts with nursing process, this is everything you need to know as a nurse. So read it, highlight it. So you always want to assess past history of surgeries and response to anesthetics, because what's our big one? Malignant hyperthermia. And we give what for that? Dantrolene. We want to assess past history, allergies, and medications. We want to assess use of alcohol, illicit drugs, and opioids. During recovery, you want to monitor, because we have post-anesthesia care, right? We want to monitor for cardiovascular depression, respiratory depression, and any complications. And then we want to implement safety measures during recovery, especially if motor or sensory loss occurs. All right. Thank you, guys.